inflammation. I hope I have set up a good understanding of what's going on in the heart. So now what we're going to do is tie together some stuff from our normal cardiac lecture and stuff from our right and left heart failure lecture. We kind of tie that together to figure out the valves. So you need to know what side of the heart, and remember we came up with that TP-MA to figure out what side of the heart the valves are on, and pretty much you already have what the sign and symptoms of these valve problems are going to be, because they're going to be right and left problems. So let's get going. So we're going to talk, really the diagnosis of having these is found in abnormal heart sounds. So you were like, oh God, here it is. Here's the abnormal heart sound section. So we're going to talk at the beginning of this about abnormal heart sounds, what they mean, and then we're going to go into some of the treatments of valve disorders. But I will tell you the symptoms of the valve disorders are going to be directly correlated to where they are located. So the first thing that we need to review is which ones are on the right side of the heart and which ones are AV and outflow valves. So this was again from the first week of class, so kind of rewind your mind. TP, tricuspid and pulmonary, are on the right side of the heart. And MA, mitral and aortic, are on the left side of the heart. The ones on top, T and M, are the AV valves in between the atria and the ventricle, and the pulmonic and the aortic are labeled for where they are outflowing to. So the pulmonic outflows from the right heart into the lung space, and the aortic outflows from the left heart into the atria, or the aorta, sorry. They're named properly. So when these valves, the AV valves are open during diastole, and they close with lub, and they are closed during systole. So opening and closed, the position, the sound you make when you are open and closed is nothing. The only sound you should hear is lub when those AV valves close. Is when they're staying closed, it should be quiet. When they're staying open, it should be quiet. Outflow valves will be open during systole because you're ejecting out to the lungs and to the heart, to the body, to the aorta. So the outflow valves are open during systole and they are closed during diastole because you're supposed to be filling the ventricle, not opening them. So lub dub, lub dub. Lub is the sound of AV valves closing. Dub is the sound of outflow valves closing. That should be all we hear. Lub dub, lub dub, lub dub. Now, of course, with murmurs, which is what we're going to be talking about, you are hearing all the other sounds. So you could be hearing all kinds of things when you're hearing. So we're going to break down that it really matters when you hear it. So I'm going to skip this slide for a minute. We're going to come back to it. Let's talk about the 5 places we listen to listen to heart sounds. So remember, when you listen to bowel sounds, you listen to all 4 quadrants. With heart sounds, there are 5 spots to listen to. You probably have learned Erb's point, which is the central location of the heart where it's good to hear almost everything. It's the best place to hear lub dub is right in the center of the heart. So you've already probably learned Erb's point, and that's just in the center of the heart, and that's where you hear lub dub the loudest, basically, because it's right over all the valves, kind of. It's the central location. But there are specific locations, and I wish I could make it easier for you, that I wish they lined up, that T was on top, and then P is on the bottom, and, M is on top, and A is on the bottom. The heart doesn't work that way. If we look at the picture of the heart, let me just go back to our picture of our heart and our valves here. Let me just, right here, you can see the outflow valves are up. They are up at the top of the heart. Oops, where did I go? Hang on. What happened here? Oh, I'm not sharing my screen. Let me go back. It closed it out. I see that. So let me just stop for a minute here. Okay. I have to share my screen instead of share PowerPoint. Hang on one second. Otherwise, you don't get to see my pictures. And that's really important. You need to see pictures because pictures are so important. Okay. Hopefully this will work now. Yes. Okay. You didn't disappear. So when we look, the outflow valves, the pulmonary aortic, are actually at the top of the heart. That's just the way the heart works. And you can see that the tricuspid and the mitral are lower in the heart. So even though we remember them, T and M are at the top and are mnemonic, TP ma, actually in the heart's kind of flipped upside down the way it feels, and just the way that the anatomy is. We hear the outflow valves at the top of the heart, and we hear the AV valves towards the bottom of the heart. So hopefully that will make a little bit more sense here when you see your aortic valve. And then, of course, the valves are a little bit twisted. So you'd think you'd hear the pulmonary valve on the right side of the chest and the aortic valve on the left side of the chest. But let me go back to, I should just copy and paste this picture and put it over there with it. Maybe you could do that if you guys are good at pictures. Where did go back? Here. I don't know if you can see, oh, for goodness sakes, me and my forwarding. I don't know if you can see the aortic valve is kind of behind the pulmonary valve there because the aorta comes up and out behind the pulmonary. The pulmonary valve is kind of, in the front and going off to the left side, and then the aortic valve is kind of behind it. So unfortunately, where we hear it doesn't correlate with where you think it is in the heart. So that being said, the top of the heart, we're looking at what the ICS is, the intercostal space. So we're talking about, our rib spaces here. This is the first me and my drawings. This is the first intercostal space. This is the second intercostal space, the third, the fourth, the fifth. So we're looking at the second intercostal space, which is basically, I just kind of look at the sternum and just go to the right and the left of the top of the sternum, not up at our notch, but kind of below that. I just kind of aim down a little bit. And you're going to listen to the right and the left of the sternum. That is going to tell us about our outflow valves, or aortic and pulmonic. So when you're listening, though, it's kind of backwards. The aortic valve is on the left side of the heart, anatomically, but you hear it on the right side of the sternum. I know. It's like anatomy wanted to screw you over. I'm sorry. But the aortic valve, so we remember the mnemonic, ape to man, A-P-E-T-M, ape to man. A is the first sound you hear. So you're going to basically walk your stethoscope around the heart in a systematic fashion. You're first going to listen, second intercostal space, to the right of the sternum. That's the aortic area. Then you move over to the second intercostal space to the left of the sternum. That's the pulmonary area, so you'll hear the pulmonary valve. Then Erb's point is down in the third intercostal space to the left of the sternum. So there's only one sound to the right of the sternum. And then you move and you just go down the heart and listen. So pulmonary area is second. Then Erb's point is the S1, S2 area. And then you go down one intercostal space, and that's the tricuspid valve. And then one more, and over to the side is the mitral valve. So the mitral valve is heard on the left side, thank goodness, but also the tricuspid valve is heard on the left side. So unfortunately, TP is on the right side of the heart, tricuspid and pulmonary, but you hear none of them on the right side of your chest, and that's just the way the heart is twisted in the chest. So the best way to remember it is ape to man, and just think aortic is on the only one on the right, and then you move over to the left side of the sternum and just listen down the intercostal spaces, and that's P-E-T-M. And you kind of walk down and listen to the left side of the heart. So what we are listening for is any murmurs, okay? We are listening for any murmurs, and what you're going to take note is an abnormal heart sound. So when you hear an abnormal heart sound, take note of where you heard it the loudest, okay? And that will give you a clue as to what valve you're listening to. So ape to man is where do you hear it? It's systematic, listening to heart sounds, we start second intercostal space right of the sternum, then we move to the left of the sternum on the second, and then we move down one to the third, and then to the fourth, and then to the fifth, and that's A, P, E, T, M. And it stands for aortic, pulmonic, herbs, tricuspid, and mitral. So that's really important, and we'll put this all together, and I'll show you how I'm going to quiz it. The second thing we hear is, what did you hear? You're going to hear two different things. It's going to be either lub, woof, dub, and this is, again, a trademarked sound that I make. Lub, woof, dub. Lub, woof, dub. Lub, woof, dub. If the woof is in between lub, dove, it is a systolic murmur, because remember, S1, lub, is the end of diastole, and S2, dub, is the end of systole. So if the noise is happening in between lub, dub, and you are not going to have to listen to anything for my test, okay? You're not going to have to listen, but I'm going to tell you whether it's a systolic murmur or a diastolic murmur. But just if you do get a heart sound thing on HESI or on NCLEX, if you hear the sound in between S1, S2, it's a systolic murmur. If you hear lub, dub, woof, lub, dub, woof, lub, dub, woof, that is a diastolic, because you heard lub, dub, and now you're hearing that woof kind of after dub. So lub, dub, that is happening. Systole has ended at dub, and now you're hearing a murmur. So when you're hearing an abnormal sound, the most important things to do is, where did you hear it and when did you hear it? It's only going to be either systolic or diastolic, and it's going to be in a spot, okay? So what did it sound like? Did you only hear it over one valve area, or did you hear it all over the heart? So that kind of helps us figure it out. So if you heard lub, dub, woof, lub, dub, woof over an aortic area, you got an aortic murmur. If you heard it over the pulmonic area, you have a pulmonary murmur. It's only heard the loudest over one location, because it's only happening in one valve. So if you hear something just in the mitral area, then you can kind of decide what it is based on what that valve is supposed to be doing. So we'll do some practice things, definitely. I'm not expecting you to be heart valve experts, but I will tell you that if you're hearing something over the aortic area and nowhere else, it's going to be an aortic murmur of some kind. The only two kinds of murmurs are stenosis and regurgitation. Okay, stenosis, and let's go back to that slide there. Now that I've kind of told you a little bit about where we're going. Stenosis is heard over the auscultation area for that valve. Stenosis is a sound when it's supposed to be quiet. That's why it's a murmur. And stenosis means that blood is having a hard time getting through an open valve. So we'll do practice, because this really is something you have to do to get. But if you hear lub, dub, woof, or a diastolic murmur over the aortic valve, we know we're having problems during lub, dub, woof, or a diastolic murmur. Is that valve supposed to be open or closed during diastole in the aortic spot? So we're listening to lub, dub, woof, a diastolic murmur over the aortic space. Is the aortic valve supposed to be open or closed during diastole? It is supposed to be closed. It's not flowing out. It's only supposed to be open during systole. So if the valve is supposed to be closed, you have a regurgitation. If the valve is supposed to be open, you have a stenosis. We only hear the noises based on, like, if you only hear the murmur during diastole and it's an outflow valve, you have a regurgitation. Now, if we heard lub, woof, dub, a systolic murmur over the aortic spot, now we're hearing noise during systole. Is that valve open or closed during systole? It's over the aortic space, but it's a systolic murmur. What is the aortic valve doing during systole? And we'll practice this over and over and over again. It is open during systole, so that is a stenosis. So this is where list makers, I think this is really hard for list makers, but I do have some lists in a little bit. I like to figure out which area we're talking about, so I know what valve we're talking about, and then what kind of, is it systolic or diastolic murmur, because basically that will tell me what's going on. If it's a sound over the aortic space and it is a systolic murmur, I have stenosis. If it's a sound over the aortic space and it's a diastolic murmur, I have regurgitation. So you have to know when it's happening so that you can tell. And I think this will be best done if we just keep practicing it, and hopefully it will catch up with you. So when you hear it over one specific valve area, we need to decide whether it's stenosis or regurgitation, and then we can chart the sound. If it's heard over multiple areas during diastole, we have, we're listening, we hear lub-da-boof in the aortic area, we hear lub-da-boof in the pulmonic area, we hear lub-da-boof in the mitral area. We're hearing it everywhere. Is every single valve? You are so lost. Can you draw any pictures? I'm going to put this all together, and we're going to do examples. I think that will help. Let's just go to examples, hopefully. Because hearing it over one specific valve area, we're going to name it that valve and either stenosis or regurgitation. I'm showing you kind of the other sounds are these diastolic gallops here. So stenosis, regurgitation, we only hear it over that one area. And we will practice that. Diastolic gallops are diastolic sounds, and they're called the S3, S4 sounds. Some of them are normal, some of them are abnormal, and they actually give us a clue on whether we have filling problems or, I just call them gallops and let it be. But they're just diastolic heart sounds, and they're in multiple auscultation areas. That is something that is indicative of heart failure. An S3 sound can be normal on some kids. Those are the kids that have problems with, I think you talked about in pediatrics, where they don't have, you can have a physiologic normal murmur for a while, and that's called the S3 sound. And that's just because they're, what is that little, the thing that doesn't close, the patent ductus arteriosus or something like that. Anyway, all I'm going to ask you to do is, if it's in multiple locations, just to call it a diastolic gallop. And in adults, it's usually the sign of heart failure. It's not valve problems. And then there's a friction rub, which is basically you can't hear anything. The whole heart sounds like a washing machine, and we'll call that a friction rub. So so we have our areas. We have, when did we hear it? I will tell you on an exam, systolic or diastolic murmur. And we have kind of our sounds here. So for the list makers, if you're not a list maker, just hold on. I'm going to get to some hands-on stuff that we can do. For the list makers who just want to memorize a list and be done with it, here's your list of systolic murmurs, okay? If I tell you it's a systolic murmur, then here's your list to memorize. If it's over the second intercostal space, right, that's the aortic sound, it's aortic stenosis. I will just give you that. If it's a systolic murmur, here they are. You can memorize this or you can think it through. I give it to you both ways. If you just want to memorize this list, these are the systolic murmurs. If I tell you it's systolic murmur and it's aortic, it's stenosis. If I tell you it's a systolic murmur and it is pulmonic, it's stenosis. But look what, systolic murmurs of outflow valves are stenosis. Systolic murmurs of valves that are supposed to be closed are regurgitation. So there's your list if you like lists. Diastolic murmurs, here are their names. Diastolic murmurs, the AV valves are supposed to be open. So if you're hearing the murmur in diastole over a valve that's supposed to be open, it's a stenosis. And if you hear it over the outflow valve, it's supposed to be closed, it's regurgitation. Okay, so If you're memorizers, I gave you a list and you can just memorize it, but you do need to know what location we're listening to so that you can know what valve you're talking about. Here's a kind of a chart too. Again, some of these might be too busy. Some of them might reverberate with you. I give you a whole bunch of different ways to look at it. Let's just go through some practice because these are all different ways to look at the same thing. And I just love this meme on this one. You don't have to grade a murmur if you scan the heart. We don't grade murmurs. We just know if they're there and they're existing or they're there and they're new, really. I'm not grading them. I'm not going to make you grade them. I don't think anyone grades a murmur. I've never graded a murmur, and I am a cardiac nurse. I'm just like, dude, that's a murmur. And I am pretty much good with my locations and good with whether it's systolic or diastolic. I leave the rest of it to the cardiologist. So remember, keep yourself focused. You are nursing students. You are not experts, and even the experts aren't experts. That's why you go to 8 years of med school and do a residency in cardiology, because then you can learn to grade heart murmurs. So let's do some practice, and I am going to give you, and let's see if we can figure this out. I'm going to give you something similar to maybe what I would give you on the test. So I'm going to tell you that I'm going to go back. Put a Band-Aid on so my thing's not blowing up. You hear a murmur on the 4th intercostal space, and it is a diastolic murmur. So you hear lub dub woof, and you only hear it over the 4th intercostal space. So what is the 4th intercostal space? What valve are we listening to there? And you will have to memorize that little heart map. So if you open up the heart map, or I could draw our little heart map here. This is the 2nd right. This is the 2nd left. And then we have 3rd, 4th, and 5th. 2nd right is aortic, and this is A, P, E, T, M. So, what are we looking at there? So it's tricuspid, we know that much. It's tricuspid, what? So if you are a thinker, you can either memorize your list, and you're like, ooh, I remember what's on the diastolic side, and you can memorize a list. Or you can think to yourself, what is the tricuspid valve supposed to be doing during diastole? So I like to kind of, if you're going to do a brain dump, these are AV valves and these are outflow valves. So what are they supposed to be doing during diastole? Are the AV valves open or closed? They are open. So it is open, which is a stenosis. Any valve that's supposed to be open and you're hearing a noise, it's automatically stenosis. So this is tricuspid stenosis. Okay, let's clear that out. No, I don't want to clear all of them. I just want to erase this stuff. Let's erase that out and try another one. We'll leave our brain dump there. We hear something over the 5th intercostal space, and it is in systole. So what is our 5th intercostal space? Yeah, the sound is because, yes, someone asked, is the sound because it's narrowed? Yes, the sound is because during systole, or when that valve is supposed to be open, it's not open all the way, and so there's sound going through it, and then regurgitation is a sound when it's supposed to be closed of it burbling back through. So we got the 5th intercostal space is mitral, and what is that mitral valve supposed to be doing during systole? Is it supposed to be open or closed? It's supposed to be closed. So it is a regurgitation. I can't spell. So we are basically saying, okay, I hear something stupid over the mitral space. I hear lub woof dub, lub woof dub, lub woof dub. And what is happening is you're hearing the sound of that mitral valve burbling back when it's supposed to be closed. That mitral valve is not closed all the way, and so you are hearing burbling back into the atrium. because that mitral valve has not closed. So when the ventricle, the left ventricle ejects, some of it, it's ejecting some of it back into the atrium because the valve's not closed all the way. So you're hearing, so if we're looking at this, let's draw here. If we're looking at this is the left side because we know it's on the left side. We're not even talking about whether it's on the left or the right, but this is we have our left atrium, and then we have our left ventricle. And this is the AV valve. Erase. This is the AV valve here. When it goes out to, such a good artist, you're so lucky you have such an amazing artist here. When this is ejecting out, this valve is supposed to be closed so that nothing gets back and it all gets directed the correct way. What happens in regurgitation is the valve does not close all the way. So now when this ejects, it ejects this way and back into the atrium. Does that make sense? So regurgitation is when the valve's supposed to be closed, it actually is burbling through. So we'll draw a picture on the map, but here with mitral regurgitation, we are seeing it's going out to the aorta, but it's also going back into the left atrium. So now you can kind of see, hey, maybe what symptoms we might have. Let's do another one. So you guys are going to be heart experts in no time. Clear off my whiteboard here. See, I was so excited to find a whiteboard that I can do on the PowerPoint. Let's do second intercostal space left side, and it is a systolic murmur. So this is what messes people up all the time. So second intercostal space, left side. You would think it would be, you know it's an outflow valve, and you know the outflow valve from the left side is aortic, but it's not. The aortic is on the right side. Second intercostal space, left side, is the pulmonic valve. Oh, I wish it was easier. So it is pulmonic valve. So second intercostal space, it's either going to be on the right of your sternum or the left of your sternum. The right of the sternum is A. We're on the left of the sternum, so that's the second spot, the P. And so it's pulmonic. And what is that valve supposed to be doing during systole? It's open. So it's an outflow valve. It's supposed to be open, so it is stenosis. And so we are having pulmonic stenosis, so that means it's on the right side. So we have our right atrium. This little boy is closed. We have our right ventricle, and we have our pulmonary artery. And this valve is just not opening all the way. So when it goes to eject, we're hearing basically the resistance. Nothing's going back to the right atrium because that valve is closed. We are hearing the resistance to flow going from the right ventricle to the pulmonary artery. So you can imagine this is hard to eject against. It's hard to eject against a stenosis. So that is what we are hearing. We're hearing it trying to scoot by that closed. We're trying to hear it scoot by. So we are hearing lub, woof, dub, but we're only hearing it in this space. We're not hearing it over here. We don't hear it anywhere else. It's over the pulmonary sound. So it's a pulmonary problem, or pulmonary valve problem. So let me clear all this up. And we'll try one more, and then we'll move on as to why we're doing all this work other than torturing nursing students. Let's do fifth intercostal space. So it doesn't matter. All of them are on the left side except for the second intercostal space. There's aortic on the right. And you're just like going to, you're like, yes, it's mitral. You are right. It is mitral. So we don't know whether it's stenosis or regurgitation until we tell you what time it is, and we're going to make it systolic. Did we already do that one? I don't think we did. So what is the mitral valve supposed to be? Oh, we did do this one. We did this one already, but let's see what it is. It is regurg, because the mitral valve is supposed to be closed during systole, so I already did this one. It's mitral regurgitation again. Let's clear that out, and let's say now, well, now it's a little bit too easy. let's change it to, let's do a whole different one. Let's do second intercostal space, right side, and a diastolic. Second intercostal space, right side, is the aortic area. And what is it supposed to be doing during diastole? Look at you guys. You guys got it. During diastole, this valve is supposed to be closed. So it is regurgitation. And the problem we have when you have an outflow valve regurgitating, so let me just draw the pictures. So aortic's on the left side, so this is the left atrium. And I like drawing them like ice cream cones. The left ventricle, and we have our aorta here. And we've got our little, we don't have a problem right now with our mitral valve. This is the aortic valve. So this valve is closed properly. So we're talking about diastole. So during diastole, this valve is supposed to be open, and it's supposed to be filling the left ventricle. And this valve is supposed to be closed. Unfortunately, the aortic valve is not closed. It's kind of open. And so what is happening is some of the blood from the aorta is dumping back in here. So during regurgitation, we have blood filling the ventricle from both sides. What this does is the blood that is supposed to be spurted out to the body is now regurgitating into the left ventricle. So when we have the outflow valves, if you had a pulmonic regurgitation, this would be happening on the left side, that instead of going to the lungs to get oxygenated, it's leaking back into the right ventricle. So the regurgitation leaks blood back into the ventricle prior to it, and stenosis makes it hard to push out. A mitral stenosis is going to make blood hard to leave the left atrium into the left ventricle. A tricuspid stenosis is going to make blood hard to leave the atrium into the ventricle, and it's going to reduce in less filling. So you kind of have to draw pictures to go with each one to understand what you're going to see. But that's what I'm kind of enumerating for you in these next ones. So let's talk about just tricuspid valve problems. We know TP-MA, that this is on the right side of the heart. The tricuspid valve is a AV valve on the right side of the heart. So it's going to affect your right atrium and your right ventricle. It's on the right side. So tricuspid stenosis, and let me see, I mean, if you want to draw your little pictures here, this is where I would draw them. You have your, now it's going to go, I didn't hit my pencil to draw. Stop it. Go back and let me have a pencil. Thank you. We have our right atrium, and we have our right ventricle. So what we are having here is that our problem is with flow out. So our valve is kind of stenosed. It doesn't open all the way. So when it's supposed to be filling this right ventricle, a lot of it kind of stays behind in here. So you end up having a dilated right atrium because, of course, blood is still constantly filling from your preload. But now it can't get all of its volume out into the right ventricle. So this ends up dilating out, and the right ventricle actually has some kind of poor output during systole because there's not a lot to pump. So decreased blood flow to the lungs and the body from tricuspid stenosis, and that's because this valve was just too tight to get blood out. Tricuspid regurgitation is where we have this right atrium and our right ventricle and our little pulmonary artery. And then we are having problems with regurgitation. So now when this thing is supposed to be closed, it's staying wide open. And this is where it's staying wide open. So now when we are ejecting, oops, I didn't mean to do that. When we are ejecting into the pulmonary artery, there was no problem filling, man. This thing filled. But when it ejects both into the pulmonary artery and into the right atrium. So we end up with blood backing up, also still dilating, because now with every ejection, it's pushing blood back into the right atrium and you're getting fill from your preload. So still decreased blood flow to the lungs and the body, because some of the blood that's supposed to be going out to the lungs is going back into the right atrium. So both tricuspid problems will cause dilation of the right atrium and decreased blood flow out to the lungs and the body. Different reasons, but same end story. And so what we're going to hear is, we certainly hear the murmur at, the fourth intercostal space, left side. And of course, if it's so here it is again. Here's our little summaries, I guess. And if it's diastolic, it's supposed to be closed, so it's a stenosis. And if it's systolic, it's supposed to be open, it's regurgitation. The reason we see atrial dysrhythmias is because this atrium's getting dilated and irritated, and so we start seeing atrial dysrhythmias, which are AFib, A-flutter, or SVT. Inadequate blood flow to our lungs can cause decreased blood pressure, increased heart rate, shortness of breath, hypoxia, because we're just not oxygenating as much blood. And this will cause, hey, guess what these are? Signs and symptoms of right heart failure. Are your lungs dry or wet? Not a lot of blood flow. They're dry. Great. So tricuspid valve problems will cause right heart failure symptoms. So it's nice if you can just remember what valve is on what side of the heart. You got right heart failure problems. Okay. So we'll look at the pulmonary side, which is the outflow valve to the right heart. Kind of the same things. It's still going to cause right heart failure symptoms, but the dilation is now going to happen in the ventricle area. So let's see, pulmonary stenosis, we have our right atrium and we have our right ventricle. And now we're talking about this valve is functioning perfectly fine. During stenosis, this valve is supposed to be wide open, but it's not really. So very decreased blood flow coming out. A lot of it sticks around behind in the right ventricle because it's just too hard to push out. This starts to grow stronger and stronger, pumping against resistance. So what happens to this right ventricle? It starts getting hypertrophic, right? This right ventricle starts getting stronger and stronger, trying to push against that resistance. And you'll end up with hypertrophic right heart failure. It's still right heart failure, though. Pulmonary regurgitation, if we have our right atrium and our right ventricle. And the pulmonary valve now is supposed to be closed. This is open and filling. And this is supposed to be closed, but it's still bubbling open. Then some of our pulmonary artery blood is coming back into here, and this is getting filled with a lot more blood. Decreased blood actually getting to the lungs because it's burbling back into the left or to the right ventricle when it's supposed to be out. And it caused right ventricle dilation, but still right heart failure. It does not cause the atrial arrhythmias because the right atrium is emptying fully and it's not getting dilated. So we don't have the atrial arrhythmias, but we still have right heart failure. So see, if you study right and left heart failure, you already got the valves, okay? Pulmonary is on the right side, and that's going to be your problem. So basically your worsening cues is worsening right heart failure. Sometimes valve dysfunction happens for a long time until you end up with a failing heart failure. So, but just look at your right heart failure signs and symptoms, and that's what you're going to see for a right valve problem. Mitral is on the left side. So we're going to talk about the problems in the left side here. These will cause big, giant, huge surprise to you guys, left-sided heart failure. So mitral valve stenosis, and you can draw your pictures here, but I will draw them for you here. This is the left atrium now, and our left ventricle, and here's our aorta. Wow, these are amazing drawings. You're so lucky. Left ventricle. So if we have mitral valve stenosis, that is up here in the AV valve. So now when this is supposed to be filling, it's supposed to be wide open, but blood is backing up into the left atrium and not as much as spilling into the left ventricle because this valve is hard to push against. And atrium walls are very weak. They don't get hypertrophic really. They just get dilated. They can't handle extra pressure because remember the lungs is kind of dumping fluid back in there like, hey, we're done with it. You can go dump it out. But now it can't get fluid out. So every beat, there's tons of blood in the atrium and pulmonary backup. Because the lungs are like, hey, we got a lot of fluid. And it's like, hey, I can't even get out the fluid we got, man. I can't even get out the fluid we got. So you get a lot of backup out of that atrium. And since the lungs are right before the left atrium, you get pulmonary backup there with mitral valve stenosis. With mitral valve regurgitation, here we have our left atrium again, and our left ventricle, and our aorta. Drawn anatomically correct. But now we have the valve is regurgitating. So during ejection, where this is ejecting out beautifully, it's also ejecting back into the left atrium, causing left atrium dilation. And of course, the lungs are still trying to fill it, but it's got tons of fluid, so possibly some lung backup. So no big surprise. We're hearing it in the fifth intercostal space, that's the mitral area, and both of them cause stretched atrium, so you get atrial dysrhythmias, decreased blood flow, inadequate blood flow to the, increased blood backup to the lung. There is an inadequate blood flow to the lungs. It's inadequate blood flow to the body. I'm just rereading this. Sorry, this is inadequate blood flow to the body. Because all of that's supposed to be going out to the aorta, not back to the left atrium. So that's inadequate blood flow to the body. It causes decreased blood pressure, increased heart rate, shortness of breath, hypoxia. But you also have blood back up to the lungs. Again, left heart sounds. I can let you draw the well, do you want me to draw it? Or do you want to draw it on your own? You can draw your pictures for aortic valve. I'll let you do that. If you have issues, let me know and I will draw you the pictures. But this way we can kind of say left side valve dysfunction is going to give you left heart failure. So you don't have to study multiple slides. You know. You already studied the heart failure slides, so you know valves. You just need to know ape to man and whether it's systolic, diastolic. So we'll go through some questions, practice you out. All valve dysfunctions or all murmurs basically is follow-up, okay? If they are if they're affecting the atrium and causing atrium dilation or atrium arrhythmias, you'll probably get some anticoagulants. Or if there's ventricular dilation, basically your doctor will decide whether you should be on anticoagulants or not. It is not a wrong thing to do with valve disorders because there's a lot of blood pooling in places it shouldn't be. So anyway, most of them, if you're asymptomatic, meaning not short of breath, not showing signs of heart failure, you're just going to get monitored, okay? Many people in the world have murmurs. If your murmur now, though, is causing heart failure symptoms, then intervention is needed. You're going to now move on to your treatments for heart failure, which are, of course, getting your heart to squeeze a little better, diuretics, nitroglycerin, antihypertensives, going to treat your heart failure. And usually, because we know it's a valve problem, they'll go in and fix the valve. But you're going to be doing your symptom treatment of heart failure. But usually their heart failure will get better if they fix the valve. So they can do treatments for heart failure, but mostly they'll go in and repair or replace the dysfunctional valve, and they will repair it either interventionally. They do a lot of these valve replacements in the interventional cardiology area, so it's not open surgery anymore. And what they'll do is they can balloon open a stenotic valve or a valve that doesn't open all the way. They kind of stretch it. They can put another valve in over the old valve. And then, or you can go in and completely remove the old valve and put in a new one in surgery. The things I need you to remember, though, is that you're either going to get, as a valve repair, tissue or a mechanical valve. So make sure your patient knows if they have a murmur just to keep going to the cardiologist, okay? The cardiologist will decide from here on out what they want to do on them. There's a ton of different causes for valve dysfunction. Some of it is hypertension. Some of them is actually getting infection on the valve. But hypertension and stenosis of the valve, like atherosclerosis, will cause. So don't even worry about the causes, but basically if you hear a murmur, go to the cardiologist and get it followed. If you're having heart failure symptoms, they're going to recommend you getting a valve replacement. The important thing to remember is if you have a tissue valve, that's actually from pig or human, if it is made out of tissue, it will only last about 10 to 20 years before the immune system attacks it and ruins it, because it's made out of either another human or porcine or some other animal valve. So tissue valves only last 10 to 20 years. So if you're a 20-year-old that needs a heart valve replacement, a tissue valve is probably not a good choice, because it will only last 10 to 20 years. They know they get eaten up, and you will still continue to be monitored while you have your valve replacement. It does not require anticoagulant therapy, though, which is an amazing option for older patients who can't safely take anticoagulants. So if you're 80 and you have a valve disorder, you're going to get a tissue valve because, hey, that'll probably last you your livable life, and we won't need to add anticoagulants to you. A mechanical valve will last forever, and you will always have a click. So you will hear lub click, lub click, lub click. You'll hear when that valve closes, it doesn't make that nice soft dub sound or lub sound. It will make a click sound. So sometimes even in the quiet room, you can hear a valve clicking. So they'll know it'll click, but you will need lifelong anticoagulant therapy, because as blood flows through this clicking valve, some of them get scraped up a little bit. And those are just pictures of all the different valves in the corners there. But I would like you to know which ones need anticoagulant therapy and which ones do not. Tissue valves do not, and mechanical valves do. But mechanical valves are usually the choice for younger patients that will need the valve to last for a while. So now we're going to talk about inflammation. Do you need a break? It's been a little while. Let's take a break till 1 and go through the rest of this after 1. Okay? Everybody go pee, and I'll see you back here in about 5 minutes. Take a quick break. I demand it. Go back. Boom. All right, so we are at inflammatory heart disease. What I'm going to tell you is inflammatory heart disease is an infection of 1 or 3 places. So we have 3 layers to our heart muscle, or 3 layers to the actual heart. So this is a great picture of the endocardium. There is a tiny, tiny, tiny little... This is this little layer here, just the layer on the inside of the heart here. So this is the endocardium. The myocardium is the actual heart muscle. So we're going to make that in red. This is the myocardium here. And then we have on the outside, we have the pericardium, which comes up with a couple of layers, but this is basically the fluid-filled sac outside the heart. And so this is the pericardial side. So the pericardium has some fluid. It's fluid filled. It's supposed to be fluid filled. And the reason it does that is so that basically you don't rub up against like your lungs. It protects that heart muscle from everything on the outside. So we have 3 layers to our heart: the endocardium, the myocardium, and the pericardium. So the myocardium is the actual muscle. Endocardium is a lining. The important thing to remember is that when you have endocardial disease, that includes the valves, because the endocardium includes the valves. So if you get an infection in this endocardium layer, this is the one that kind of folds in and becomes your heart valves. So that is a concern, that when we get an infection of your endocardium or your endocarditis, you end up with valve disorders, and that's because the valves are a piece of your endocardium. So, that being said, why do we care? What could go wrong? Well, when your heart is inflamed, again, it doesn't get to take a break. There's no days off. There's no quarantines. It's essential services. When your heart is inflamed, whether it's the muscle or the outside or the inside of your heart, you get impairment of your valve function or heart contraction, and then you have decreased cardiac output and signs of heart failure, depending on how bad this disease is. So we're going to look at endocarditis, which is the interior side, and that is now swollen and red and sore. This is where our blood will run up against the endocardium. It's on the inside of the heart. And infection of this endocardial lining is infection of the valves as well. And debris, so remember, if this thing is inflamed and infected, the white blood cells are going to be in there trying to fix things up and clean things up, but it's going to create inflammation, swelling, vegetation, and bacterial growth can get onto the heart valve surface. So what we're looking at here is usually the most common cause of endocarditis is strep. And rheumatic fever is what we call endocarditis from strep. So strep is one of our main causes of endocarditis, and the other one is IV drug abuse. IV drugs, when you're directing dirty IV drugs right into your system, well, they're going to flow through the heart. They're going to infect the innermost layer of the heart. So your two most common causes are strep and IV drug abuse. IV drug abuse is starting to come up on the most common, but basically untreated strep can lead to rheumatic fever. What do we do from it? What do we expect? Well, now we're having a high fever because it's an infection of your heart valves. It's an infection of your heart. A very high fever will go along with this. Chest pain because your heart is hurting, literally. If you have rheumatic fever, you will have the other ones. If you've done it doing IV drugs, you'll only have the first two, a high fever and chest pain. If you have rheumatic fever, I should probably put there's a line there. These are really the two cues of having infected heart muscle. These go with rheumatic fever. So if you have, if you've injected and given yourself an infection from, you may not have the painful swollen joints and skin rash. That goes with rheumatic fever. That's part of disseminated strep. So you got a fever, you got chest pain, you go into the doctor, they give you antibiotics, great, you're cured. If you ignore it, there could be worsening conditions. One of them is that basically the two big worsening problems, you think heart valve problems are bad enough, but unfortunately when things get worse is you've got these little areas of bacteria and vegetation, and you might see this word Aschoff's body. You might see those in test questions and things like that. Probably not my test questions, but I've seen it on tons of NCLEX questions. These are actually just seen on echo and stuff on the valves. They're vegetation on your valves, and that is from the infection. And basically, when you have a white blood cell infection, when you have a UTI, you kind of pee out casts, which is debris. This is debris from the white blood cell, basically trying to clean up things. So you get debris on your valves. It can cause scarring and deformity of the heart valves. It can cause stenosis or regurgitation. But really, we're looking at this one and bacterial emboli. Those are our two big problems as things get worse with endocarditis. You get vegetation on your valves that cause valve dysfunction, and you get bacterial emboli because, hey, you got bacteria in your heart. Guess what it's pumping out? It pumps out huge clogs of bacteria, and you basically get a bloodstream infection. These two kind of go together. Bacterial emboli and sepsis. So we want to kind of treat this. The treatment is very easy. It is, here's, of course, the things that you want to monitor for. Of course, I keep forgetting to monitor your heart. You're going to listen to heart sounds. If you know you have an endocarditis, you are listening for new or worsening murmurs. you're going to be listening to lung sounds and peripheral edema mostly for any signs of heart failure from those murmurs, and you're going to be keeping an eye out for those vegetative emboli. They do show up as strokes, pulmonary embolus, or some kind of ischemia. And then, of course, why are we not monitoring? Stupid. Someone should catch me. Temp, white blood cells. I mean, it's an infection, for goodness sakes, or sepsis. Somebody, what did you just say? It went behind the recording icon here. Does that mean no high fever with rheumatic fever? No, you have a high fever with rheumatic fever as well. It's a bacterial infection, so it will come with a high fever. I do believe I said that both of those, high fever and vague chest pain, go with any kind of endocarditis. The swollen joints and skin rash only go with rheumatic fever. Okay, so both of these go, high fever and vague chest pain goes with both, any kind of endocarditis. So what we're going to do to fix it is do blood cultures to identify which bacteria it is. We know there's a bacteria in there causing endocarditis. We will give antibiotics because it is an infection of some kind. If you do have joint and inflammation, nonsteroidals and steroids are great at reducing the inflammation around the heart. And don't you love the lasagna or endocarditis picture? I mean, come on now, you're never going to forget endocarditis. And you'll never forget what Ashoff's bodies look like because, yeah, ew, gross. Which one? Just for funsies. This, oh, I don't even remember. This one is endocarditis. Oh, go back. Ugh. Man, I need to learn how to work my pen. There we go. That's the one I want. Just for future endeavors, this is endocarditis. This one is lasagna. That one is endocarditis. This one is endocarditis. That one is lasagna. I actually have no clue on that one. I'm going to say endocarditis. This one's lasagna. That one's endocarditis. And that one's lasagna. There's the answer key. But anyway, what we're going to say is it is a infection of your heart. You are not having a heart attack, but you will need to take your entire antibiotic therapy or you will become further sepsis, valve damage. And then if rheumatic fever, well, and actually with any endocarditis, even if it's drug related, we don't want any rheumatic fever causing further damage to the heart. So with any history of endocarditis, they will do prophylactic antibiotics before any invasive procedure. So they need to report their history of endocarditis because they've already had damage and one infection of your heart and of your heart valves. We don't want to get rheumatic fever at all. They don't want to get, they're going to have to treat their strep infections, but also we're going to do prophylactic antibiotics for any invasive procedure, whether it was IV drug related or rheumatic fever. Again, rheumatic fever is the most common cause of endocarditis, but any endocarditis, the patient has to report that to the physician before any invasive procedure, whether it's a root canal, whether it's, you know, a biopsy, any surgery, a hysterectomy. You don't need to let them know that you've had endocarditis so that you can get prophylactic antibiotics before surgery. The difference in the amount of prophylactic treatment is you're going to get prophylactic treatment for 5 years if your valves did not have any involvement. So you just had endocarditis, you took your antibiotics, and it's over now. They're still going to prophylaxis you for 5 years. If you had valve heart disease or any kind of valve involvement, you will get lifelong antibiotic prophylaxis. So after endocarditis, there is a takeaway. We cannot afford you to get another infection that gets in your heart, so you will be taking prophylactic antibiotics. And that applies for any surgery, okay, any procedure. And dental procedures are dirty, so, you know, there's a lot of germs in your mouth. And so you'll get prophylactic antibiotics even for a cleaning, probably after rheumatic fever. It just means that anytime you're mucking around with germs, you need prophylactic antibiotics. 5 years if you did not have valve disease, and lifelong if you have valve disease from your endocarditis. Myocarditis is an inflammation of your actual cardiac muscle. Ooh, hurts like it feels like an MI because it's an inflammation and swelling of your actual cardiac muscle. How do they compensate the intestinal flora with such a long time on antibiotics? You won't be on antibiotics like every day for the rest of your life, but you will be on for any invasive procedure. So anytime they need to do any kind of anesthesia, whether it's local or general. So think about when we're going back to talk about the endocarditis teaching. Tell your patient anytime they need a procedure that's going to involve anesthesia, whether it's local or general, they're going to need prophylactic antibiotics. So they're only taking the antibiotics around the procedure time. So if you're going to go in and get a root canal, even though that might be local anesthesia, you still need prophylactic antibiotics. Anytime you get an incision on something or you're getting any kind of procedure. So if you're going in to get an ablation of something, or you're going in to get your uterine ablated, even if it has nothing to do with the heart, if it requires local or general anesthesia, you're going to prophylact it. And Margaret was saying that it goes with even cleanings. That's just because the mouth is so full of germs that if you're going in there and you're causing bleeding and there's germs, that it could get absorbed, and you're just at much more risk for, after your first infection of endocarditis, to get a second infection of endocarditis. So we just want to prevent any kind of infection. So they will ask that question, and if they don't ask that question, we need to no, it's not an everyday thing, just a couple of days before and after the procedure. Good question, though. All right, so myocarditis is an infection of the actual heart muscle, and this is usually a viral infection. So endocarditis is usually bacterial. Myocarditis is usually viral. It sometimes happens 7 to 10 days, like the virus actually gets in there, and they think that COVID has an element of myocarditis to it because COVID is a virus, and they're finding that a lot of patients post-COVID are having some myocarditis with them. A lot of viruses like to get in there and embed into muscles and cause secondary problems, and they are seeing an increase in myocarditis after COVID. So that is one of the things that they're looking for after COVID, is looking for myocarditis. So usually after you recover from your viral infection and then you start having, chest pain, it's not constant chest pain like endocarditis is, because you're constantly flowing blood past the bacterial infection. Here, this is worse with inspiration because the heart is actually swollen. And then when you inhale, you kind of rub your lungs up against this big swollen heart, and it's basically like banging a sore thumb. I mean, if your thumb is swollen and you keep banging it, it hurts. Well, basically every time your heart is swollen and every time it beats, and when the lungs inflate on top of it, it starts to hurt. So it is kind of a chronic, dull chest pain. It gets worse with inspiration. When you listen to lung sounds, you hear washing machine lung sounds. It's hard to hear the lub dub because there is so much swelling in the heart space that it starts to mask your lub dub sounds, and it just makes a friction rub sound. So most of our cardiac surgery patients, I can't hear lub dub to save my life because they all have swollen hearts. It's not due to a virus, it's due to them actually going in and doing surgery on the heart. But swollen hearts just make a lot of noise. So myocarditis, though, is an infection of the actual heart muscle. It's usually viral, so it goes with a low-grade fever. And they may have tachycardia, some ST segment changes. They may have just some basically what looks like, it's not ischemia of your heart, but it is kind of injury to your heart. So you might get what looks like injury. It's not really an MI, it's an infection. But the doctor will be taking a look at them and double checking and following them up. But some of our cardiac surgery or cardiac MI patients, when they finally get down to the cause behind it, it's not an MI, it's myocarditis. They look very similar because there's actually damage to the heart muscle going on while it's swelling. So anyway, the key points for myocarditis is that it is usually viral. It usually has a low-grade fever with it, and a tachycardia, which is what we're seeing on a lot of patients after COVID. Actually, a lot of my nurse friends are having some of this that had COVID, had no symptoms, went back to work. But now when they go back, now the gyms are opening up. I've had like 2 or 3 friends that had COVID, had no side effects from it, but now get super tachycardic and short of breath if they try to do any kind of exercise at all. And then they go in and see the doctor, and they're like, yeah, you probably got myocarditis. It's just a post-viral irritation of your heart. If it just causes low-grade fever and tachycardia, they just let things heal, treat the chest pain with anti-inflammatories. So here, let's go on to the, of course, we'd keep an eye out for any kind of heart failure, make sure the infection doesn't become worse. And it is a virus, we usually have to let it run its course. Cardiac rest. Restricted activity, so this is not the time to go back to the gym. So all my friends who went back to do their cross-training workout got tachycardic and short of breath, and the doctor said, yeah, you got myocarditis, sorry, chill. No exercise, just rest it out. Cardiac rest is the best thing, kind of like when you get the flu or COVID, there's really not much we can do. You have to rest it out and let it run its course. They can do blood cultures to see if it's viral or bacterial. Antibiotics, antivirals, possible, but really I shouldn't even put that in there, because depending on the viral source, there might not be an antiviral for it. I'm going to move that down here. This is really the big, this one and cardiac rest. If they think it's myocarditis, if you have a history of a viral infection, especially in this post-COVID time, they will say cardiac rest and non-steroidals and anti-inflammatories, or maybe some a course of steroids to try and reduce the inflammation. And then if things are not getting worse, they will probably move on to cultures, antibiotics, antivirals. But really, rest and non-steroidals or steroids. Okay? And because it's viral. So just, let them know, rest. If they're on antibiotics or anything, they take them, but really anti-inflammatories and rest. Pericarditis is the last one, and that is the inflammation of the sac around the heart. And this has specific pain. This is sharp pleuritic chest pain. So the other one is pleuritic as well, myocarditis, but it's dull. It's not sharp. It's not like, oh my God, I'm having a heart attack. It's more like this dull ache all the time that's worse with deep inspiration. This is sharp and super painful with deep inspiration, because this isn't the muscle that's swollen, it's the sac outside the heart that's swollen, and so the lungs rubbing up against it really irritated really strongly. Sharp pleuritic chest pain, which means it's worse with inspiration and when laying flat. It's usually referred up to the shoulder and upper back, feels a lot like an MI. The only thing that relieves pericarditis pain consistently is leaning forward, like if you're sitting at the bedside table, like leaning all the way forward, almost like tripoding position, because you actually let that heart kind of hang a little bit and move it away from the lungs. But this is a swelling of the sac around the heart. It usually has a low-grade fever, and when you do your 12-lead EKG, because they come in thinking they have a heart attack, or they're thinking they're having a heart attack because it is painful, they will do a 12-lead EKG probably on all of these. On endocarditis, there's probably no EKG changes. On myocarditis, it will be mild, or it will be... it'll look like an MI, and they'll go in and do things, and you find clear coronary arteries. I'm not saying that there's a great way to figure this out. They usually have to do other diagnostic tests to determine whether it is endocarditis, myocarditis, or pericarditis. You usually are getting 12-lead EKGs and echoes to take a look at the heart. I mean, we really can't just walk in and be like, oh yeah, you got pericarditis. There is other diagnostics going on. But the real big difference is that myocarditis has low-grade fever and dull pleuritic chest pain, and pericarditis has sharp pleuritic chest pain and a low-grade fever. This one definitely has ST elevation in all leads. So it makes it look like they're having a massive MI, where the myocardium and the endocardium are perfectly fine. It's just that what's being transmitted out is all the irritation on the outside of the sac. And you hear a friction rub. So a lot of these, it's so swollen. Whenever anything is swollen, you start the ability to lose, you can't hear the S1, S2, and you only hear, you listen to the heart and it's unbelievable. It sounds like a washing machine. The worst thing that can happen with myocarditis, the actual heart muscle can get so infected that it doesn't pump well. Here, the actual heart muscle can get squished. If the swelling outside in the sac starts squishing in on the heart won't beat very well, and that's called tamponade. Tamponade means, pushing in, putting pressure on. And so this effusion all around the heart, basically the fluid starts taking up more and more space, pushing in and causing pressure on the heart. For pericarditis, nobody wants to hear this, but the only treatment, again, is to reduce swelling and inflammation. Non-steroidal anti-inflammatories and corticosteroids, just like with myocarditis. Because pericarditis does get better when you sit upright and lean forward, head of the bed elevated over bed table for them to tripod onto, the pain will decrease with time. If things start getting to the point where you are getting increased pressure and decreased blood flow through the heart, they will go in and aspirate the fluid out from around the heart. And those are just any pericardio procedures are taking something from around the pericardium. So a pericardiocentesis is pulling blood from the pericardium. Pericardial window is where they actually cut a little piece of the pericardium and let that fluid kind of escape to prevent causing pressure on the heart. And they can actually remove your pericardium. But then again, now your heart has no protective surface. So they kind of do that as a last ditch resort. But any pericardio procedure is doing something to the pericardial sac. So if you see pericardio anything, that's the sac outside the heart. With these, we're going to take a look at the EKG. You will not be surprised to see STA segment elevation in all levels because that is typical of pericarditis. The pain level will be sharp, worse with inspiration, feels better when you lean forward. The heart sounds as a friction rub. The big thing, since the main complication of pericarditis is that pressure on the heart, you're going to be looking for cardiac tamponade, and I think this picture is a little bit better, showing you kind of the pushing in that sac does. It doesn't expand very much, and so when there gets more and more fluid in that sac, it starts pressing on the heart. And as the heart gets pushed, the heart rate will go up. You'll get a decreased blood pressure because there's less blood flowing out of the heart. Narrowing pulse pressure means your systolic and diastolic are coming closer together. So when you hear narrowing pulse pressure, that means like instead of just dropping down to 80/40 or something like that, you're 80/60. 80/70, your pulse pressures are coming closer together. So it's a specific kind of drop in your blood pressure, and it means your systolic and your diastolic come closer together. Because your afterload's not really changing, but your systolic pressure is decreasing. So what's happening is really what we see with patients that are having a tamponade problem is that they start dropping their blood pressure, but their diastolic pressure doesn't change. And so sometimes we have patients that are 90/75 or 80/60. That's called a narrowing pulse pressure. Weak pulses, because there's not a lot of perfusion as it's getting squished, and cool climate, basically no lack of perfusion. Instead of hearing the friction rub, you hardly hear anything, because all you're hearing when you put a stethoscope to chest is fluid. Like even the heart sounds can't transmit through the fluid. So you don't even hear the friction rub anymore. You just hear muffled nothing. It's kind of like listening to diminished basses in the lung sounds. You're listening and you're like, oh, there should be a lub dub, there should be a friction rub, there should be some noise, and you just hear. It's actually kind of scary to listen to because the heart sounds can't transmit through the fluid. So we'll keep an eye for those complications. Basically the treatment of pericarditis is the same as myocarditis, cardiac arrest. If you get an antibiotic, antiviral, take the entire course, but it's anti-inflammatories and rest. Yeah, everyone should avoid alcohol and drug use while your heart is healing. The last thing we need to talk about, and I'm trying to save a little bit of time for quiz questions so that we can apply this, is aortic aneurysm and dissection. I just want to point out that your aorta goes all the way down until it branches off down at your femorals. So your aorta has two different parts. You have the thoracic part of it, and you have the abdominal part of it. Any part of the aorta is our main artery. Any part of the aorta can have trouble. And an aneurysm could be in any part of any blood vessel at all, but an aneurysm is just a bulge in the artery. And a dissection is where blood starts to flow through that bulge, and you actually have blood flow in the blood vessels. So I'm gonna draw again, getting back to drawing. If you have your giant aorta here, the blood vessel has 3 layers to it. There's a couple of different layers to the blood vessel here. Got kind of your blood vessel wall here. So if this starts getting weak, so if this first layer starts getting weak, it starts to bulge out. So let me see, I didn't draw that properly. That's what it's supposed to look like normally. And when you have a aortic aneurysm, it kind of bulges out, but your vessel walls are intact. And what happens when it dissects is now blood flow. So blood flow is now kind of turbulent in there. So let's draw some blood flow. Blood flow is kind of turbulent in there, and it kind of turbulence around in there, but it keeps moving. With dissection, some of this blood flow actually pops through this wall and starts traveling down in the vessel wall, which really, really hurts. The vessel wall is not meant to have blood flow through it, and a dissection, which usually only happens in the aorta because the aorta is under such high pressure, that when blood flow starts leaving and going into the vessel wall, creates a great deal of pain. So having an aneurysm, okay, you have one. A dissection really, really hurts. And then, of course, the worst case scenario is where it's not just dissecting, but now it starts popping out and you have an arterial bleed into your thoracic or abdominal cavity. So it's kind of like grading it. The aneurysm is having a bulge. The dissection is now blood flow is actually getting into the vessel wall, and then a perforation is where it actually starts pumping out into your cavity. So you could tell, not a good thing to do. Just having a aneurysm is usually asymptomatic. Having it in the thoracic area does come up with symptoms sooner. There's not a lot of room in your thoracic area. Your thoracic area is above the diaphragm, holds your heart, holds your lungs. There's not a lot of room for a big balloon in your aortic area. So you may feel like you're having trouble swallowing or shortness of breath because the lungs can't expand as big. The esophagus is right there, and it's innervated by the same nerves that are around the aorta. So a swelling of the aorta can cause trouble swallowing because your esophagus is running right behind your heart there. If it's getting worse, you have intense persistent. So if this starts to dissect, or the bulge gets really, really big, you could have chest or back pain. Because of where the aorta is located in your thoracic area, you have chest or upper back pain because this aorta is causing a lot of pain and it's in your thoracic area. In the abdominal area, there's a lot more room. The abdomen can hold a lot more and can contract and move around a little bit more. So they're usually asymptomatic until they're very, very large or actually dissecting, which causes a lot of pain. If you just have one and you're very, very skinny and you don't have a lot of extra padding, you might notice an aortic pulsation in your abdomen, but you can actually hear this turbulent blood flow down in the abdomen there. You can't really hear it up in the aortic arch because it's up too high and it mimics with the heart sounds. But down in the abdominal area, you'll hear this turbulent blood flow, which is known as a bruit. And how do we know if that's getting worse? You'll have abdominal or lower back or flank pain, because this is now dissecting in the abdominal area. So a little bit different levels of pain because of where they are. And of course, the worst case is the whole thing ruptures and causes no blood pressure and no loss of consciousness. So we're going to keep an eye for the worst case scenario is blood pressure. If you haven't, so there's a beautiful picture of the aneurysm rupturing there, which is basically a ruptured aneurysm has like a 10% chance of survival. It's an aorta. If you rupture it, there's not much time to save you. Most ruptured aneurysms don't do well. What do you think if you have a bulge in your major artery that's due to pressure? What do you think you want to do to keep everything from getting out of control? You want to keep a low blood pressure. You're definitely going to keep an eye on any pain level location. If the patient has a large aneurysm or already has a dissection and we're waiting to go to surgery or something like that, keep an eye on that pain level. Worsening back pain with a thoracic, or an abdominal aorta, worsening back pain, chest pain, flank pain is a sign that they could be dissecting, because dissection hurts really bad. The size of the aneurysm, if you just have an aneurysm, they watch it. And if it gets to be big, then it gets surgical. But you want to keep an eye on a patient with a known aneurysm or recently diagnosed aneurysm on the blood pressure and the pain level. And then, of course, perfusion. It'll decrease if we start diverting our aortic blood flow into the blood vessel or into our abdominal or thoracic cavity. So our treatment is to keep the blood pressure low. We want to lower your blood pressure. If it is dissecting, we will keep your blood pressure super low. A blood pressure of 90 is good for a dissection because it's already diverting blood flow out into the vessel wall, which is hurting. And as we drop people's blood pressure, their pain goes away because it's now not under so much pressure that it's diverting into the vessel wall. If you just have an aneurysm, you want to prevent it from getting worse. Maintain your low blood pressure there. It prevents dissection and rupture. If you already have dissection, it will reduce the dissection. If you already have rupture, you're probably dead. But if you just have an aneurysm, you will maintain a lower blood pressure to allow that healing to happen. Surgery is what's left as an option. Really, once you have a dissection and a rupture, surgery is your only chance to fix it. They don't like to do surgery unless you have a large aneurysm, and that's larger than 5 centimeters or 2 inches. So, I mean, you can get a pretty big aneurysm, and they'll just control it with blood pressure and serial monitoring. But once that aneurysm gets large, they will do surgery on it. And you can imagine surgery on an aneurysm is not a good surgery. It's not a wonderful surgery at all. You actually cut off blood flow to your body while we repair the aorta. So the only way to fix it is to put the silicone graft on and put in a new aorta, basically, and it involves suturing the aorta, clamping it, which means no blood flow to your body while this is happening. They have to put you on bypass, and they put in a new graft, and you can imagine the sutures afterwards, very delicate. It is a very, very high-risk surgery. If you've ruptured, it's the only surgery that will fix things, but this is the kind of, if you have an aneurysm rupture, most patients don't even make it to surgery, much less through the surgery. So it is a last-ditch effort. We will try to maintain things with blood pressure control. So there's your education on it, and that is the end of that.